Great. So our fall 2024 seed grant cycle applications are open through Monday, October 14. The center funds 2 awards, $35,000 each for 12 months, and that will start on January 2025. And you can visit our website for more details. The Dunlevie Center is now on LinkedIn. Next slide. Our next speaker for October will be Dr. Jenna Miller. She's an assistant professor of gynecology and obstetrics and surgery, and she will be talking about serial amnioinfusion for fetal renal failure, the RAFT trial. So please join us for that talk. Today, we are so fortunate to have Dr. Ann Borders speaking to us. I could say wonderful things for an hour, but I'm going to close my mouth and hand it over to Dr. Deirdre Lyle, who will make the formal introduction.
Yeah, thank you. And I will try to keep it quick, but I can't because she's done so many different things. So I am honored to introduce my old friend, Dr. Ann Borders. As briefly as I can be, Dr. Borders earned her BA in biology from Ohio State.
Iowa State.
Did I say? I said Ohio. Did I?
It's okay. That's the only thing I would ever correct you on.
Yeah, I'm so sorry.
Iowa.
You're not a Buckeye. I'm sorry. Ohio State medical degree from Harvard Medical School, a master's of science in health policy from London School of Hygiene and Tropical Medicine. She completed her OBGYN residency at Brigham and Women's and Mass General, that's where she and I met. Her MFM fellowship at Northwestern and earned an MPH and a postdoctoral fellowship in health services research at Northwestern. Currently, she is the executive director and obstetric lead for the Illinois Perinatal Quality Collaborative. It's a collaborative of more than 100 hospitals that are focused on improving birth outcomes for mothers and newborns. She also serves as the Illinois Perinatal State Quality Committee, serves on that, as well as the Maternal Mortality Review Committee and the Maternal Health Task Force. Dr. Borders is also the Horowitz Endowed Chair of Obstetrics in the Division of Maternal Fetal Medicine at North Shore University Health System and is a clinical professor at the University of Chicago. Her research is funded by NIH, CDC, HRSA, and PCORI, and it focuses on understanding and addressing disparities in maternal health and pregnancy outcomes. She's authored many peer-reviewed publications, as well as many ACOG committee opinions, particularly with our own Dr. El-Sayed. She's also received multiple awards, excuse me, including the Best Abstract Award at SMFM from the oral plenary session. I think for anyone who doesn't know what that is, and to get an oral presentation at SMFM, it's a big deal. To get into the plenary session is sort of like, one thing you hope to do in your career. And she had 2 oral presentations in the same plenary, which I don't know that anyone else has ever done that. But of course, they both won awards for the best of session, as well as the Norm Gant Award for the best research in maternal medicine at that meeting. That the oral was on reducing time to treatment for severe maternal hypertension through a statewide collaborative. So really important stuff. In addition to that, as I mentioned, she's been a friend and colleague for 25 years. I first met her in 1999 when she, just right before her intern year, she'd returned from getting her master's in London, and it was very clear that she was going to move on to do very big things someday, as she has done. So Ann, thank you so much for joining us. We know that you're quite busy. We look forward to your talk today on your work at the Illinois Perinatal Quality Collaborative and your important work on birth equity. Thank you. I'm going to ask questions that they could be put into chat, and I will moderate them at the end. Thank you.
Thank you. Thank you, Deirdre. I was on my very first night of call with Deirdre, and I remember her telling me, put down the call, going to be okay. I remember being called. So my very first night of call as a resident was with Deirdre. So we'll go very far back. I'm really excited to talk with you today about the work we're doing in Illinois. And it's really about moving to action. And I think that many of us probably on this call have worked on disparities research, have been thinking for a long time about how to improve outcomes. And this talk is really about how do we move to action? And what does that look like? And just show you some of the things that we've done in Illinois to make that work. So I have no conflicts to report. I am a white physician who's been doing disparities research for 20 years. I grew up in rural Iowa, in a town with significant poverty during the farm crisis, which I think has really impacted my career trajectory. These are some of our funders for this work that I'm sharing today. I'm just going to talk, I think we all understand the urgent need to address birth equity, but just to really give us the kind of viewpoint where this work comes from, I'll talk briefly about our approach from our Perinatal Quality Collaborative. I know there's a lot of amazing work, really where it started is in California, trying to understand how Perinatal Quality Collaboratives work. And certainly Jeff Gould's on the phone today, who helped me really think deeply about how to start our collaborative in Illinois. So many of the things we do in Illinois really comes from our partnership with California. Very briefly, I'm just going to touch on our Mothers and Newborns Affected by Opioids initiative, just because I think it's important, and I want to show how we kind of weave equity into the work we do, even when we're not directly working on birth equity, like I will talk about with our birth equity initiative, and how that is so important. And I think something that we're all moving in that direction, but we have to do it better and faster. So just to position you on what it looks like in Illinois, where I live and work, this is from our Maternal Mortality Review Committee, which I've sat on for a long time. The light green is our 2015 to 2017 data, and then the blue is more recent data coming right up to 2020. So it was the first year of the pandemic. We have seen a slight reduction in our Black mortality, but not sufficient, not enough to close our gap. If the gap is closing in Illinois, it is a little bit because we've seen a reduction in Black maternal deaths, but we've seen an increase in Hispanic and white. Much of that has been driven by our opioid pandemic. But this is what it looks like in Illinois. And then this is what it looks like for our Medicaid deaths. And what we saw was a significant increase in Medicaid deaths from moving from 2015 into 2018 to 2020. And so as we think about equity and how we're going to address and work on it across our state, one thing that was really important to us was to bring everyone to the table. Initially, I think some of our hospitals from our rural areas felt that that equity wasn't what they needed to be focused on. And I think we really talked deeply and long with them about how they need to identify the disparities that exist in their hospital, in their space, in their communities, and take action. And so certainly that's what we've done or tried to do across Illinois. I think it's really important, and I don't have time in this talk to go into this. I like to usually start a talk by going into each of these components and really spending time talking about Liz Howell's work and Hall and others who've really demonstrated the impacts of systemic and structural racism, how bias impacts care outcomes in obstetrics, how resources impact our patients, and then how quality of care is impacted by all those things. I'm going to just say that we are going to think about how do we move to action by thinking about disparities through this framework, so that we can really think about how do we identify bias and work to address it. How do we think about quality of care and standardization of care to improve outcomes? How do we think about stress and our patient experience and what our patients are experiencing in terms of their quality of care? So what has been our approach? ILPQC, like Perinatal Quality Collaboratives across the country, is really a matrix that brings people together. And it is a place where we can really learn from those around us who are trying to work and improve outcomes for our pregnant and postpartum patients. It's a place where we can really lean into partnering with patients and the community. When we were starting ILPQC, EverThrive, Illinois, which is right there to the right next to ILPQC, they were one of our really key partners. I mean, there was 4 of us who were really starting ILPQC, and one of them was EverThrive, and they're the kind of largest patient and community-based group in our state that works on maternal health issues. They helped develop our logo, and they were there with us from the beginning. So we started ILPQC really thinking about how we can bring community and patients together with hospitals, public health, and others to make an impact and to move to action. And that was a thing that we've talked about always, is it's not enough just to educate people. It's not enough to just identify what the problems are. We have to figure out how to move to action, and then we have to figure out how to scale so that we can actually make differences that shift how we're caring for patients and shift outcomes on more of a population level. That's what we've tried to do. And we've tried to think about how to do that equitably and to be improving outcomes and addressing and reducing disparities, because it's not enough to improve care and improve outcomes if you don't have your eye on the disparities. If you don't have your eye on how to do it equitably, you can worsen those disparities and worsen the disparity gaps. So really important that we look at this from that viewpoint. So what do we do similar to what the California Maternal Quality Collaborative does? We engage hospitals to create an environment of improvement. We motivate hospital teams to facilitate change at their hospital, and then we support them through collaborative learning opportunities. They can learn from each other. We use rapid response data. Our teams submit data monthly, and we're constantly looking at how their data looks compared to other hospitals around the state, really talking about their data and understanding it. And we do a lot of quality improvement support. Our goal is to leave no hospital behind. The smallest hospital, our safety net hospitals, what do they need to succeed? And then how do we motivate and engage people? A lot of it is emotion. How do you create an emotion where people believe that they can improve? They feel motivated and bought in, and they understand why. And so we do a lot of patient stories. We have patient partners that really work through all of the initiatives and really are in front of our teams a lot, that really help demonstrate the why, and are I think a huge motivation for why our teams really think about what they need to do and why they need to do it with some urgency. So we're now been ILPQC for 12 years, and we really think about how we work together, how we engage patients and communities, and constantly how we make change happen. I'm just going to briefly talk about two of our initiatives today. The Birth Equity Initiative that started in 2021 and is now moving into our sustainability phase, and our Mothers and Newborns Affected by Opioids Initiative, and to use those to think about how we think about equity. But you can see we've been working on initiatives, and the peach or the orange is our neonatal initiatives, and the blue are obstetric initiatives. So really briefly, we have a major issue in Illinois with maternal overdose deaths. This is an issue that's really seen across the country. In some ways, when the CDC reports mental health and then asterisks substance use disorders, we in Illinois ended up pulling the two apart so we could look at mental health deaths and substance use disorder deaths separately. And what we found is in its most recent report we just released in 2023 is that 32% of our pregnancy-related deaths were from overdose. And we've seen just a significant increase. And certainly on Maternal Mortality Review Committee, we've had to really change the way we do reviews because we've had so many overdose deaths to review. We really think about how we message the initiatives that we do, because it's really about the why and understanding how do you get people to move to action. And what we found, certainly with our opioid and substance use disorder work, is that OB providers in particular thought this was a social work issue. They didn't see it as an obstetric issue. They didn't see it as a maternal mortality issue. And so we learned really quickly we had to really message this. We made posters and really went on the offensive to really think about how do we get this in front of people as an urgent crisis and get obstetricians thinking about this issue. These are some of the key messages we used. I'm not going to go into all of our key strategies, which were really about how do we do a better job of screening and linking patients to treatment and linking to follow-up and really reducing stigma and improving empathy. And all of those things, we knew we can reduce overdose deaths, improve pregnancy outcomes, and really think about the mom, the maternal, the parental baby unit. So this briefly is some of the data from this initiative. And like I said, I won't go into detail about all the different strategies that we did, but this was what we were able to do. And we started out, only 41% of patients in Illinois who had a diagnosis of opiate use disorder had been linked to treatment, were on medication-assisted treatment, or were linked to recovery treatment services, even mental health services at the time of discharge from labor and delivery. Again, it was just seen as like a social work issue. Someone would come through with OUD, and the biggest thing that the clinical team seemed to think about is who is going to call DCFS and who is going to call neonatology to tell them there was a baby at risk of NAS. We really shifted that narrative to say the patient in front of you is the highest risk patient on your unit right now who's at risk of maternal death. She may not die in front of you, or she may not die in the OR, but she could die 2 weeks from now on her bathroom floor if she's has a relapse. And so really thinking about the severity of this condition, we were able to dramatically increase the number of patients who were linked to treatment and linked to medication-assisted treatment and follow-up services. And then we were able to sustain this work after we moved out of our active initiative really successfully. And I said that within our work, one of the things we've really focused on is how do we think about this from an equity standpoint? And so stratifying your data when you do quality improvement is incredibly important. So we did this from the beginning with this work. And one thing we found pretty early on is that we were seeing a huge disparity in linkage to treatment. So our Black patients here in the orange compared to our white patients in the blue, Black patients were linked to medication-assisted treatment about half the time that a white patient was. And a lot of that has to do with stigma and bias and availability of resources and all sorts of things that were able to be addressed. These were not unsolvable problems. And it really meant identifying and addressing and standardizing care so that every patient needed to be provided resources to receive treatment. And we were able, over the course of the initiative from 2018 to 2020, really completely close this disparity gap and improve linkage to treatment and services for all patients with substance use disorder, something we're really proud of. So at the time that we were doing this work and really identifying these disparities, it was around 2019. We've been working on the Substance Use Disorder Project. Our teams at the time, and this was before COVID, this was before the George Floyd murder in 2020, this was 2019. Our teams were voting on our next initiative. We have about 400 people in a big ballroom, all the obstetric hospitals in Illinois, and we vote on initiatives. We'd already planned to do the promoting vaginal birth work, and we asked, do teams want to take on a second initiative? And someone stood up and said, I think we really need to work together on birth equity. Everyone was in agreement that this was important. We've been bringing a lot of birth equity work in front of our teams, and that was voted on. And we spent about a year working on it. And then in July of 2021, we launched our birth equity initiative across 81 hospitals in Illinois. And you can see, I think when we first started this, the very first time we talked about it, hospitals said, is this just an initiative for our Chicago hospitals? And it became really clear that this was really, really necessary statewide initiative to understand the experience of our Black birthing patients, the experience of our patients who don't speak English, the experience of our Hispanic birthing patients, the experience of our patients receiving Medicaid. Where were our patients, where were disparities being identified, and where was bias being identified, and how do we address that with actionable strategies? A lot of this was getting birthing hospitals to the table and believing that we can make a difference, and believing that there were actionable strategies that they needed to put in place. And we were able to really effectively, I think, get a lot of really committed people on board in the middle of the pandemic. You know, it was going on in July of 2021. Our birthing hospitals had been decimated with staffing shortages, and we had 81 hospitals showed up to that first meeting to launch this birth equity initiative, which was really, really exciting. This work was done with partnerships with patients and community groups, our community advisory board, patient partners who really helped guide the development of this initiative and figure out how we were going to develop actionable strategies. We also worked really closely with other PQCs, including California. We were meeting monthly for a while with states really interested in moving birth equity together forward, and that really made a huge difference to us. And I think, as always, when you're doing something hard, really leaning into others and thinking about lessons learned and how do we keep moving forward, how do we work on being successful, what can we learn from other states, what can we learn from our community partners, our patient partners, to do this well. We did a whole series of focus groups with Black birthing patients who delivered in the last year all around the state. And that really drove a lot of this work. The information that came out of those focus groups, that qualitative data, was incredibly important to us. So these were the key strategies that were settled on: optimizing race and ethnicity data collection, and then reviewing stratified data to identify disparities and take action on them, screening all patients for social determinants of health, and then working to link patients to needed services in the community, standardizing postpartum safety education, scheduling early postpartum visits, engaging patients and community members for quality improvement input, implicit bias and respectful care training for providers, nurses, and other staff, and then sharing respectful care practices and surveying patients before delivery discharge on their care experience and feeding that data back to hospital teams. So I'm going to take you through some of the work that we did on these key strategies. This was our really thinking about implicit bias and respectful care education. I think I could talk about this for a whole talk, but I will just sum it up to be that it's really about layering this in and doing it over time. And it is a constant discussion. And I think this is what our hospitals learned. We had a huge number of hospitals that moved from using e-modules. A lot of them did that diversity science training to just start having their teams and providers thinking about this work, but then really move to regular small group discussions. A lot of them did these documentaries with discussions. We had a lot of them go through the anti-racism speak up training, the Laboring with Hope movie, Aftershock, others. I think the work became something that the teams were really proud of, and really led into some of the work we're currently doing on respectful care to have these conversations over time. This is the staff trained across the state who worked on implicit bias, respectful care training across providers, nurses, and staff. We worked on social determinants of health screening. When we started, very few hospitals in the state were doing social determinants of health screening on their labor and delivery units in their prenatal care places. So the graph at the top, green, red means you have not started working on it yet. Yellow is working on it, and green is in place. And this is our structure measures to say, are you putting our actionable strategies in place? And when we start an initiative, most everyone's in the red, and then people move pretty quickly to start working on it. And others are kind of like, oh, other people have started this strategy. Everyone else is in yellow. We're still in red. What's happening? Oh, everyone's starting to move into green. We need to get working on this strategy. So this work really moves like wildfire to help hospitals really understand what others around the state are doing. And it pushes people to keep moving forward and get these systems changes and strategies in place. And this was really about how do we effectively screen, and then how do we effectively link patients to community resources. We use electronic resources like findhelp.org. And then we also did a lot of partnering with community, engaging community partners. This is a random sample. All hospitals in the state collected 10 charts per month. And then they looked to see whether there was social determinants of health screening documented in the delivery admission. And then if someone screened positive, they looked to see whether there was documentation that they were linked to community resources. This is from about 23,000 charts that were sampled. And as you can see on the left, we had a significant increase in social determinants of health screening. We really implemented this across the state, and then really improved hospitals linking patients to treatment, to resources. I think when they started, hospitals really thought about this as something only the social workers needed to think about, and there's just not enough social workers in the world to link our patients to treatment, to resources that they need to. So really briefly, how did we help them make these really meaningful connections? How do we start thinking about what it means to have community partners? A lot of our hospitals worked pretty hard at this. So on the left was some of the work that we did around expanding resources for hospitals to identify home visiting programs in their community. And on the right, helping hospitals link to community-based doulas. These flyers were put together by some of our community advisory board members, some of our doulas, home visiting nurses, and others who work with us. And our hospitals really, it was this like opening up of realization that they really needed to better understand their community partners. So a lot of them started doing activities in the community, really focusing on meeting patients where they are, participating in more community events. This picture with the balloons is one of our birth equity teams from a hospital down near St. Louis, and they started going out and participating in community events, community baby showers, and then really figuring out how to partner with community organizations so they could better figure out how to do referrals for linking to resources, and then better understand the capacity of their community partners. Here are some of our hospital teams doing doula staff trainings and doula meet and greets. So these are all real pictures from birthing hospitals in Illinois, really thinking about how to move this work forward and what does it mean to get their labor and delivery staff more aware of how to work with doulas and how to get doulas in the community more aware of what's happening on their labor and delivery units. Our teams, like I said, also worked on home visiting programs. This middle is from a Peoria hospital, looking at making connections with their home visiting program. On the right is a document one of our hospitals put together, all these different community resources. And it just says, yes, I want that. Let's talk more, not now. And it describes what that community resource is. And a lot of our hospitals love this, this document. Sharing respectful care strategies. So I'm just going to briefly talk about respectful care because I want to get to one other thing. We worked a lot on respectful care, these respectful care practices. Some of these ideas came from work here in California. And some of them, a lot of them came from our focus groups with Black birthing patients. We created a poster in English and Spanish and sent these posters out to all the birthing hospitals in Illinois. These are the respectful care practices. I'm not going to spend time going through each one, but you can kind of get a sense, you know, what are your goals for labor and delivery? What's important to you? What are your concerns? How can we best support you? Partnering with you for all decisions, practicing active listening, personal boundaries. Those are the kinds of things that our patients, these patients in the groups who helped build this document talked a lot about. Our teams did a lot of work figuring out how to share these respectful care practices, both with their staff and also with patients, because they wanted patients, when they came onto their unit, to know what they could expect in terms of respectful care. And everyone started just talking about respectful care all the time. It was just something that it's a very constant conversation. And when you're having constant conversations, that's how you lead to culture change. Here's some of our hospital teams working on respectful care implementation, signing posters, nurses working on individual elements of respectful care, putting up posters, putting up all sorts of work in their on their individual units. Working on respectful care, one of the things was really important is that we weren't just talking about respectful care, we were then asking our patients, did you receive respectful care? And then feeding that data back to the individual hospital teams. So we did a PREM survey implementation across the state, asking patients whether they received these respectful care practices, and then fed that data back to hospitals in a stratified way so they could look at it to see if what their disparities were. So it's really working on respectful care practices, asking patients if they received it, and then feeding that back to the team. So we've had over 12,000 PREM surveys submitted across 76 hospitals with a representative sample for Illinois. And what we've seen here on the right, which I'm not going to spend a ton of time going into, is that we were able to improve respectful care. This is a question I felt pressured by the healthcare team and accepting care I did not want and did not understand. You kind of see over these 6-month increments that the number of patients responding that they felt pressured accepting care they did not want or did not understand reduced. But the other thing I want you to identify is that there are clear disparities between Black, white, and between public and private insurance. And although we were able to shrink that gap, it is still there. And so that's one of the things we're actually working on. We're bringing in Team Birth through a PCORI grant to work on shared decision-making and active listening with our teams to continue to work on knowing where our disparities are in terms of respectful care and how do we address them in a really intentional way. The thing we talk to teams all the time about this respectful care and shared decision-making, it's about recognizing patients as the experts of their own experience so we can improve our active listening and empowering patients to make choices through accessible, non-judgmental communication. So this is kind of like our mantra. Engaging patients, community, and work. We really work, this is the thing probably the hardest, is to get our hospital teams to bring patient partners onto their QI teams and to really get patient voices in front of their clinical teams. So we did this in 2 ways. We worked on working to get patient partners on quality improvement teams. We also worked on something called Respectful Care Breakfast, which was bringing, getting hospitals to have a breakfast. Instead of a grand rounds, we say held a breakfast, invite patients who delivered in the last 2 years to come in with their support person and their partner and have a breakfast and talk about respectful care and their care experience and where you can do better and where you did well. And this has been something that's been really successful. We talk about a lot of different ways to get patient and community input, but we just want it to be some way. So there's so many different ways you can get patient voices in front of your QI teams and in front of your clinical teams. Really important to hear patient voices at your grand rounds, to hold a respectful care breakfast, engage patients on your QI team, or develop a patient community advisory board. But the getting patient voices in front of both your clinical team members and your QI team members is what helps us move to better, faster. We're always going to know the direction that we're supposed to be going in if we're listening to what our patients are telling us. So we started by trying to model this for our hospital teams around the state. We did 10 regional community engagement meetings. We brought in patient and community partners and facilitated connections and conversations between hospital teams and these patient community partners. It was really successful. We found respectful care matters, involves connecting people as individuals without judgment, includes listening, discussing, providing explanations. Feedback from patients is critical. Hospitals have to work with community stakeholders to identify existing community resources and address unmet needs. These are all quotes. Care coordination is necessary. Meaningful change requires input from patients' community. So really important things that we learned from our hospital teams and from our patient partners. And what our hospital teams realized is that, wow, that was incredibly helpful to hear from patient partners and community partners. And so they were willing to take on these respectful care breakfasts. And we started doing these around the state. We've now done over 40 hospitals have held respectful care breakfasts. So here's some pictures. We want to hear your voice. Let's talk respectful care. Bring your baby. Let's talk. And it really is about getting doctors and nurses who provide obstetric care to listen to patients telling their stories. Lots of feedback. I mean, across the board, everyone loves respectful care breakfast. Doctors, nurses, patients, everybody who attends really thinks about this safe place where people can share and people can listen. And we really can hear how we can do better. Here's some more of our respectful care breakfasts around the state. I learned to involve patients, patient partners I felt truly listened to. So this is just our summary, what we've been able to accomplish. These are our structure measures that I told you each about. Where we started, very few of our hospitals had these really important equity strategies in place on their units. And by June of 2024, you can say we've hit our goal of being over 70% of hospitals for all these actionable strategies. And then what did those actionable strategies do? Because it's not enough to put systems changes into place. We have to show, are we making a difference? This is one of our outcome metrics, which was reducing disparities in NTSB C-section rates. And our hospitals have been working on this. And this is looking across where things stand from baseline, Black patients in red and white patients in blue. And this is some of the strategies that we asked our teams to work on in order to very intentionally work on addressing their NTSB C-section disparity gaps. And all of these things are components that they've worked on through their birth equity work. This is our Take Action flyer that we actually share with all of our birthing hospitals. And again, it's these same strategies I've been talking about throughout this talk: understanding the data, identify the disparities, share that back with your clinical team, actively listen and get input, engage, educate, and improve, expanding doulas and midwife work, and really thinking about how we connect our clinical team to move to culture change. And with that, we feel like we've been able to take action. We're now working on sustainability, so continuing to share stratified data with clinical staff and identifying those steps to take action, continuing to engage community partners to improve linkage to resources in the community, so really working on expanding doulas and home visiting programs, and then finally really continuing to get those patient and community voices in front of our quality improvement teams, but also our clinical teams as really important sources of feedback. So in summary, urgent need to take action on birth equity strategies. Patients' experience of respectful care matters to improve care and outcomes. Listening to patients and communities tells us what changes are needed. Build collaboratives where you can find them to help make change happen faster, and then consider how you can take action. It will take ongoing intentional change, really intentional, to move the needle forward. And it's really about taking action. And this is one of my favorite quotes, because I think this is what PQCs do. It really brings people together to be able to make change happen. Thank you guys so much. Our website has all of our birth equity resources on it at ILPQC.org, and that's our PQC's email if you want to reach out to me.
Great and wonderful talk. Thank you so much. Just a reminder for people to put questions in chat, but congrats just on this really incredible, impactful work. And the fact that you've closed equity gaps while you've been improving outcomes for all is really, really remarkable. And it's the goal that we are all working toward. I like your quote, these are solvable problems. 100% they are. Couple of questions and from the chat. First of all, there's a ask, are your slides available?
Sure.
Wonderful slides, a lot of good content, and got a lot of good learning. I have to say, this is where California is learning from Illinois. So thank you for your earlier comments on learning from California, but boy, you're doing some great work. From Christina Oldini, when you talked about your substance use disorder program, she asked if Illinois has a program similar to California Bridge. And that looks like a kind of 24/7 support program. Christina, don't know if you want to come off mute and say a little bit more.
Hi, Anne. Thank you.
Hi.
Great presentation. Yeah, I'm just wondering if Illinois has something like California Bridge. They were so supportive in our substance exposure work. If you have anything like that, which is basically putting navigators and those that can start MAT in emergency rooms. And then we brought to their attention the need for that for OB services and the idea of even starting obstetrical patients. And I know not all hospitals do that, but some do, are willing to start OB patients on MAT. So that's what I was just wondering.
Yeah, we want them all to start it. And we didn't even leave it as a question. I was like, this is life-saving. So we have something called MAR now, but I couldn't agree with you more. And I actually have been talking about this with the CDC and ACOG and SMFM. The SUD issue has to be solved both on labor and delivery units and in emergency rooms.
Yes.
And we have to have the ability to navigate patients immediately at that time to treatment and then a coordinator who can continue to navigate them, because the problems are too challenging. And when you're in the throes of an addiction, which is a acutely life-threatening condition, we can't send someone home and say you should really get into treatment. And for our pregnant patients, the postpartum period is such a high-risk period when they go home and often lose resources and support and have a really difficult time. And so we use MAR now. I think what you're doing was putting navigators into emergency rooms is incredibly helpful. We actually partnered, I developed this module for emergency departments education. It's like a video that does both mental health and then substance use disorder, what our emergency rooms need to know. Because I think we saw that as one of our key issues. Our MAR Now program is 24 hours a day. You call, you get linked to a navigator coordinator, and then they do buprenorphine home starts for pregnant patients, however. So they're start doing telehealth treatment because so much of we just couldn't get, where a lot of our deaths are happening are mid-state, downstate, our small hospitals. Yeah. And so we needed a situation where we could do telehealth. So they do buprenorphine home starts, and then the care coordinator pays for transportation. They call the pharmacy, find out if medicine's there. They get the patient in a Medicar, and they take the patient to the pharmacy, get the medication, get them home, and then they have their success at getting patients in for ongoing treatment and then successful follow-up is like over 90%. It's kind of amazing data.
That is amazing. Thank you, Anne. I so appreciate that.
Yeah, it's incredibly important, and we really have to think about overdose as a leading cause of maternal death, and we have to think about really ways to help our hospitals figure out how to do this, because our clinical teams, our OB clinical teams, they often feel that they weren't trained to manage addiction and talk to patients about Narcan. I could have given a whole talk on that subject.
Yeah. One other question. Go ahead, Deidre.
No, go ahead.
I was going to ask about, I just met with the state yesterday about our numbers in California. We have the highest rate of, I believe, of congenital syphilis in the nation. And I'm wondering if, one of the barriers we're facing also is in the ERs is getting folks treated. Yes, we have our challenges with screening, but having people treated who are homeless and are not in permanent housing, to get them treated on the spot versus turning them away in hopes that they'll go back somewhere. So it's
Yeah,
kind of
they
a
don't.
similar, it's the same thing.
Same issue, and it's a crisis for you know, that we're having these incredibly preventable neonatal outcomes. And so I similarly, we have a phone number that we're trying to get emergency rooms and OB providers to call, because I think what happens is people get really confused by syphilis. And so we have similar, we're trying to figure out education. We've done a syphilis education through our PQC with outpatient settings and emergency rooms. And it's really about making sure people feel supported and they know how to do treatment. And then there's all this like tracking, right? That you have to know, like people have gone to 3 different hospitals. Did they get treatment? Did they not? But I think that this is where systems changes, where we're addressing these like really acute public health crises. PQCs have to step into that space and really think about systems that work at scale. And systems that work at scale are like 24-hour, you know, place someone can call and get support to know how to start treatment. So it's really thinking about what we can do to scale that will work for our biggest hospitals and our smallest hospitals and our emergency departments.
Thank you.
Yeah, thank you. We're almost out of time. I wanted to ask a couple questions. This came from Christina in chat too. I had the same one though. Is equity training mandatory in your state?
Mm-hmm. It is now. It wasn't when we started this work, but we work with a lot of our legislators. But the problem with mandatory equity training by itself, I mean, and you guys all know this, I don't have to, I'd probably say this to anyone on this call, is that in a vacuum, we really don't know what mandatory equity training does. It's quite different to think about like what we really took on, and people think about this different. There's a lot of discussion about how you can't do a separate equity initiative. You need to bake equity into every initiative you do, which is true. But I feel like what we did was take a pause and say, these are really important actionable strategies that we need teams to really focus on. And what we found is that we kept trying to move to culture change. And so doing a e-module by itself is not going to move to culture change on your labor and delivery unit, but having repeated discussions about things and talking about respectful care and thinking about respectful care. And those respectful care breakfasts, our teams are now doing them. A lot of hospitals are doing them quarterly. Once they do one, they're just really hooked. Because if you get your doctors and nurses hearing from a patient about what their experience was as a non-English speaker on their labor and delivery unit, and you have a mom sitting there telling her story, and you have a whole room, doctors and nurses. So we found that and we broke up these breakfasts where everyone was at different small groups, different tables. And there was a mom and partner at each table, and doctors and nurses just having conversation. Everyone had a name tag with just their first names on it. And everyone had breakfast together. And something about sitting and eating with someone really removes that hierarchy, and people are just able to talk. And then there was a panel of patients. Not all the patients wanted to share their stories. Some just wanted to be there. We had a panel of patients who wanted to share their stories. And then usually most patients want to go around and share something. And so many of the doctors and nurses said it's those small things that we do or don't do for patients that make patients feel seen and heard and taken care of. And that's really about moving that needle on respectful care for all patients. And what does it feel like to be a patient who's come in, who's receiving Medicaid, who feels like they're not receiving good care? What does it feel like to not speak English and have a nurse not use an interpreter service? What's that feel like? And that's, I think, the biggest thing we found to shift culture was those kind of experiences, not just mandatory IS training. Deirdre, there was another question. I'm sorry.
Yeah, so there's one more in chat. We're at time, but I want to address Dr. Igmanos's question very quickly. Just a thank you. And can you speak about which intervention you felt was most helpful in decreasing the disparities in cesarean by race?
I think that the number one thing, honestly, was stratifying the data and showing the data to the teams, to clinical people. I think people were not aware of the disparities on their units. I think that stratifying data and then really showing the data all the time. This is our disparity gap. What is causing it? And then they did deep dives to try to better understand what was driving the C-sections for Black patients versus white patients. So a lot of our hospitals looked at their ACOG SMFM criteria and looked at deep dives using our dashboard to say what was driving our higher rates of Black C-sections. And then digging it, it's like unpeeling an onion. And they're looking to say, why is that? And then bringing in patients who could share stories to say, what do we think is happening here? And so it's really doing the investigative work to understand the why. If anyone's heard, Allison Bryant, my good friend from Boston. She shares a lot about this, like really using your dashboards to really understand the disparities and then dig deep to understand what's driving them. And then the culture change, respectful care, that really matters for patients' experience. And I can't stress enough understanding what those respectful care strategies are. But a lot of doctors and nurses will say, I provide respectful care. That's why I come to work every morning. But really moving those respectful care breakfasts and patient stories in front of teams, that's where we started to see culture change.
Great. And thank you so much. This has been really a fascinating 45 minutes. We should have had 2 hours because I know that there's many more here, but I wanted to turn it over to Yasser for final words.
Thank you. And thank you so much. It's just wonderful to see you, even if it is on Zoom. And thank you for being such an incredible leader in our specialty. We learn so much from you and everything you do, and look forward to having you back to talk to us in the future.
I'd love to. Everyone, I have so many friends there, and I really appreciate the work you all do and the impact it's had on me, for sure. From Deirdre to Yasser to Elliot, who I know is not here today, and to Jeff, wherever he is in this. So thanks, everyone. Let us know how we can be helpful. We're always interested in collaborating, and have a great day. Thanks for having me.
Thank you. Bye, everyone.